Hello everyone. Today I would like to present regarding the global health challenges in a lower middle income country, the disease burden, health inequities, and interacted framework strategies for Malaysia. As economies grow into middle income status, their health profile shift. Malaysia illustrates the pattern. Rapid development, aging, and urbanization bring a heavy burden of chronic disease before all the infectious disease threats have been resolved. It involves epidemiology transition, which the disease profile shift from infectious illness toward non-communicable disease, but the transition is incomplete. Both burden now coexist one health system. Health inequities is outcome diverge sharply by income, geography, and ethnicity. Rural and East Malaysian population face weaker access to care and higher out-of-pocket costs. System and financing strain, rising chronic care costs, a growing aging population, and workforce pressure test a system that spends a relatively modest share of gross domestic products, roughly 4 to 5% on health. The dual disease burden in Malaysia, it carries a rising non-communicable disease load while communicable and re-emerging infectious persist, compounding pressure on the same health system. Non-communicable disease account for an estimated 67% of all deaths in Malaysia. Diabetes prevalence reached 15.6% and adult overweight obesity 54.4%, among the highest in the Western Pacific. The risk is shifting to younger cohort, and many cases go undiagnosed until costly complications appear, such as dialysis, cardiac stroke. It's driving long-run treatment costs roughly 3.1 billion ringgit Malaysia per year for diabetes. The driven costs are urban diet, sedentary lifestyle, tobacco, and aging, while communicable disease such as dengue, tuberculosis, and zoonosis persist, with outbreak tied to climate, urbanization, and mobile migrant population often outside formal coverage. A vulnerable, hard-to-reach segment sustains transmission. Vector-borne risk rises with warming and unplanned development, blurring the human-animal environment interface. This caused by climate, housing density, cross-border movement. The two burdens are not sequential but simultaneous, competing for the same finance, workforce, and infrastructure. Managing one at the expense of the other erodes overall system's capacity, the core low middle income country dilemma. As a lower middle income country, Malaysia must fund and staff a full modern chronic disease response while still fighting infection that richer nations have largely controlled, defining lower middle income country squeeze. The non-communicable disease, type 2 diabetes, is 15.6% of adult, roughly 3.6 million people, lead to dialysis, amputation, blindness. Whereas cardiovascular disease, such as hypertension, 30% of adult, top cause of death. Cancer, such as breast, colorectal, lung, often diagnosed late, while chronic kidney and respiratory disease, mental illness, rising long care demand. Two disease front one strength system for the dual burden detail in communicable disease, such as dengue, tens of thousands of cases yearly, climate and urbanization driven. For tuberculosis, roughly 25,000 notified cases per year, concentrated in the urban poor migrants. HIV and hepatitis B and hepatitis C persistent in key and hard to reach population, while zoonosis and emerging threats such as leptospirosis, rabies, Nipah, and COVID-19. The two fronts collide in the same patient. TB reactive in poorly controlled diabetes. Dengue is deadlier with heart or kidney disease. And COVID-19 hit non-communicable disease patient hardest. One patient, one clinic visit, two overlapping burdens and a system that must treat both at once. Malaysian non-communicable disease burden in numbers. National Health and Morbidity Survey 2023 figures place Malaysia among the highest burden countries in the Western Pacific, while infectious disease pressure persists in parallel. We look at the data. Overweight or obesity consists of 54.4%, while diabetes is 15.6%. Hypertension is 30% and high cholesterol is 33.3%. All of it, 67% of death in Malaysia are attributed to non-communicable disease. It's roughly 3.1 billion ringgit Malaysia estimated annual cost of treating diabetes and its complication, and 3.6 million adults live with diabetes, with prevalence reaching 15.6% of population. How determinants generate inequity and strength system? Health outcomes are shaped less by clinical care than by the condition in which people live, work, and age, distributed unevenly across the population. It divided into three. Firstly, social. Social is like in education and health literacy gap, ethnic and rural-urban disparity, marginalized groups such as orang asli, migrants undocumented with limited access, led care-seeking behavior. For economic, it is out-of-pocket spending and catastrophic costs, income inequity shaping diet and risk, productivity losses from premature non-communicable disease death, and fiscal limits on public health financing. While environmental, climate change expanding vector range, rapid unplanned urbanization, air quality haze, sanitation pressure, deforestation, raising zoonotic spillover risk. The resulting strength of the health system determinants convert into a widening equity gap. The poorest bear the highest non-communicable disease and infection risks yet access the least care. The system faces double financing pressure, prevention plus complex chronic care, overstretched primary care and workforce, and rising demand that outpace budget undetermined resilient of the next shock. The integrated framework strategies such as universal health coverage, sustainable development goals, and human animal environment, each defined and applied through a concrete cross-sector integration. Example, for universal health coverage, all people access quality health services promotive to palliative without financial hardship built on strong primary care. For Sustainable Development Goal, it consists of 17 goals to 2030 that treat health as linked to poverty, education, water, gender, and climate action, while One Health, Human, Animal, Environment, a unified approach balancing the health of people, animals, and ecosystem cross sector and disciplines. One integrated multi-sectoral strategy anchor delivery in UHC primary care as the shared platform. Use the SDG agenda to fund the mobilized non-health sector against determinants, embedded One Health surveillance to close the infection and environment loop. Together, they build a resilient, equitable system that manage multiple burdens at once. Now we look at the recommendation and implementation roadmap. A phased multi-sectoral roadmap for Malaysia include three phases. Short term, which is reach until 2 years. It's called as Stabilize Protect. It's expand primary care screening for diabetes, hypertension, and TB at clinic level, catastrophic out-of-pocket costs via targeted subsidies for the B40, strengthen dengue and outbreak surveillance in high-risk district. The medium term is about 2 to 5 years. It is integrate and finance. Move toward UHC financing that pools risk and cover non-communicable disease chronic care, embedded health in all policies across housing, food, and education. Launch Joint One Health surveillance linking health, veterinary, and environment agency, while the long term is for 5 to 10 years is sustain and equalize, achieve equitable UHC coverage, closing rural, urban, and ethnic gaps, build climate resilient health infrastructure and workforce capacity. Sequence don't silo. Each horizon builds delivery capacity for the next, with equity, system resilient, and multi-sectoral ownership as the constant thread from clinic to cabinet. The conclusion and key takes away: one, dual burden; one, integrated response. Malaysia challenge is not choosing between disease, but building a system that manage both equitability and sustainability. The problem is a simultaneous, not sequential burden. Rising non-communicable disease and persistent infections compete for the same finance, workforce, and infrastructure. Social, economic, and environmental determinants concentrate risk on those who can least afford care, widening the equity gap. The response integration, not isolation. No single framework is sufficient alone. Then finally, the path: sequence, equity, lead, deliver. Three, stabilize, then integrate, then sustain across three horizons. The bottom line is managing one burden at the expense of the other erodes the whole system. A resilient, equitable Malaysia depends on treating population health as a shared, cross-sectoral investment from clinic to cabinet. I think that's all for now for the presentation today. I hope you get some message from it. Thank you for listening.